four days of a very good session on the various aspects of faculty development program that we are conducting. Today, we thought that since this particular topic is the bread and butter of our specialty and being so vast, in fact, it encompasses so many aspects of, endodontics, basically, right from prevention to to heroism, I would say. Prevention in terms of not doing endo and heroism in terms of doing endo for the impossible tooth. So there is so much more to understand how to train your students in this vast topic. So we have only one presentation today by Dr.NIMISHA Shah. And for that, to introduce the chairpersons and the speakers, I call upon Srijana to start the proceedings and do the answer.
Good afternoon, everyone. It is my utmost privilege to introduce the moderator for today's session, Dr. Vibha Hegde. Vibha ma'am is the professor and head of the Department of Conservative Dentistry and Endodontics at YMD Dental College, Navi Mumbai. Ma'am, over to you. Thank you.
Good afternoon. And first of all, I would like to congratulate Team SRM for the wonderful academic contributions that they have had over a period of time and which I have witnessed. And I congratulate Maha ma'am and all her dynamic team of youngsters who are equally involved in all these activities. And I am very glad to be a part of this program today here. And Dr. Nimisha Shah today, who is our speaker for this session, she is one of my very personal favorites, and she also knows the reason why I suppose. But I have watched over her academic contributions over a period of time, and it is very impressive. And there is also a lot of feedback which I have seen from her students who are also students of YMD, and that says a lot about her academic involvement. And I congratulate her for all that. And to give a brief introduction of her, Dr. Nimisha Shah has earned her MDS from GDCEH Ahmedabad in the year 1998 and is currently a professor and head of KM Shah Dental College and Hospital, having 24 years of teaching experience as well as academic credentials like a recognized inventor. 5 copyrights, 2 design patents, editing 2 book chapters, ICMR projects, and membership on the editorial boards of 3 national and 1 international journals, as well as the member of Board of Studies Academic Council and institutional research committees, among others. She has received the Journal of Conservative Dentistry's Best Original Research Award of 2015 and Endodontology's Best Clinical Research Award in 2021. She has received a training in doing dental procedures using a microscope, CBCT analysis, and a 3D treatment plan. She recently finished a master's fellowship in microaesthetics at Savita University, Chennai. And I think this is a very short CV, which I have said, and she has much more contributions than this. And I invite her over to take over the stage. Thank you.
Thank you. Okay, good afternoon. Thank you so much, Vibha ma'am. You are always supportive and encouraging to me. I do not know what is the reason, but somehow you are always there with me and provide me the support and to uplift myself and even in association and various part. So thank you so much, ma'am. Another sincere thanks to Mahalakshmi ma'am. Ma'am is like a, what can I say, mentor and a friend and a helper and whatnot. I can tell anything to her and she will be there to support and encourage and do whatever we say, and like a solid rock support to me. I am congratulating to the entire team of SRM, Madam Rajkumar sir, Sujata ma'am, and many more I know now, Madana and Shrujana, of course, and Janani, and so many. They have a very dynamic staff, and the entire staff is working tirelessly for each and every event. So thank you so much, and congratulations to the entire team. So the topic which I am going to present today is revamp, curate, and teach root canal treatment. Now, believe me, when this topic was given to me, I was like, what I'm going to speak, particularly to the, faculties, like, that what will I teach them in the root canal part? So I was very much confused. So I kept on asking Madam, what do you want me to present? And then she shared some tips to me. And based on that, we have prepared this presentation. Now, this presentation, as we all know, root canal treatment is a very vast topic. And from our first day of MDS till now, we have attended multiple workshops, and each topic, it's like a one-day workshop in this. So I have not covered any theoretical aspect, but rather I have only given a clinical tips in this presentation, and I hope they will be useful to you all. So is it now everything is audible, visible? I can start my presentation.
Yes,
finally?
please.
Yeah. Okay. So I'm just putting off all the thumbnails, so I will not be able to see anything. Please stop me if anything is going on the other side. Okay. So now, as the name suggests, it's a root canal treatment. So before treatment, I feel it's more important part, which as a faculty, which we have to see is a diagnosis. So diagnosis play a very important role before we do a treatment. Then comes the treatment planning, and finally the execution of the treatment. Now we all are busy in a day-to-day OPD. Our departments are the loaded departments. We always take care of the maximum OP of the college. So it's always possible that we will be casual sometimes when somebody just show us an X-ray and say that, what, sir, what should I do in this? Or what, madam, what should I do in this? We said, looks like deep. Just start RCT. Mostly it will go for RCT. Similarly, they'll come and give us some complaint only that patient is saying he's having pain since yesterday night, tenderness bhi hai. And we will say, okay, start RCT. So dear faculties, even we know that there is something called as a provisional diagnosis and final diagnosis. We teach this to our students. But it not out of the ignorance, but because of the burden what we have, multiple tasks what we have to do, we often ignore certain aspect that will stand up and go and see the patient actually. So there are many hidden findings. Like, for example, a tooth is having a non-restorability. The lesion is such that it's periodontally weak. There is an extremely deep, well below the gingival margin, where we cannot save. Second is, sometimes like the periodontal aspect or other aspect are not being observed by the patient. Some soft, white spot lesions or another kind of lesions are there, which they have ignored. So rather than focusing on the one treatment, I feel that we have to always come to the final diagnosis before we decide for the execution of the treatment. That's a clinical signs and symptoms coinciding with the radiological interpretation and with the pulp sensibility test. When we are well assured about all this, then and then please start the treatment. Now in oral cavity, we do not have one type of pain. It's odontogenic, which is mainly pulpal, periapical, or periodontal. We even come across many non-odontogenic pain. And the problem with the non-odontogenic pain is the pain mimics exactly like an odontogenic pain. So it is characterized as an atypical odontalgia. So where you have a prolonged periods of throbbing and burning pain in the teeth or alveolar process in the absence of any identifiable odontogenic anatomy, etiology. So that means that when this patient will come to us, we do not have an actual knowledge about this non-odontogenic cause and its differential diagnosis. So we limit ourselves and try to correlate this pain with the odontogenic pain itself. And this sometimes leads to misdiagnosis or unnecessary treatment. It exacerbates patient symptoms and causing an irreversible damage to the patient. So my advice, or I normally do this, okay, when I am failed to find any odontogenic cause, I refer that patient to my oral medicine department, where I have a 1 or 2 trusted persons and they will be helping me out. Or rather, I personally prefer to go and visit along, go to the department along with the patient, because the way they diagnose, the way they gradually take a radiograph or do various tests, and they'll help you out to know which non-odontogenic pain is also responsible, not the odontogenic one. So this is a very effective way. And believe me, there are 4 or 5 patients which I was not able to, deal with. They have managed them so well. And this even help us to, differentially diagnose various non-odontogenic pathologies, with otherwise we have not coming across daily. Many times we even have a combined pain of this. This is of course very rare. So here also, I would request that you focus on the chief complaint of the patient, be it a odontogenic or a non-odontogenic. So with the start with either of the treatment first, or many a times we even have to simultaneously start the treatment and wait for the results to come. So please listen to the patient. When we are not able to diagnose, we normally say that, yeah, this patient is very irritating. Every time he comes, there is nothing in his mouth. It's not like that. Always patients are right in majority of cases. It is we who are failing in diagnosing their pain. So please pay attention to this. So here I have mentioned some conditions which commonly we come across, but we are failing to diagnose. The most common out of that is a sinusitis. We all know it's a continuous dull or lingering pain, particularly in a maxillary teeth. Teeth are mild sensitive to percussion and patient have a pain on mastication. But the classic sign, or like classically how we can diagnose it, you palpate in an infraorbital region. This will elicit a pain, as well as ask the patient to bend down his head below the knees on the dental chair. Allow him to sit for 3 to 4 minutes. If by doing this, the pain is increasing, that means he is having more pain related to sinusitis and not the tooth. Neuralgic pain is very common. We all are very much aware about it. It's a severe throbbing, shooting electric shock like a pain, which lasts for the few seconds, or even lingering pain is also observed. Mostly unilateral, exaggerates in the winter season, and they have a trigger points. When it's a migraine pain, we have a photophobia or a phonophobia, and this aggravates in a stressful condition. So you ask patient all the medical histories or what type of pain he or she has. Rheumatoid arthritis. Now here, in this condition, it causes tenderness, stiffness, and pain while chewing. But at the same time, patient will have a history of pain or inflammation in other parts of joints as well. So it's not related to TMJ, but other joints are also involved. So systemic history of the patient is very important. Glossopharyngeal neuralgia in a similar condition have a severe pain in tongue, throat, and tonsils along with the teeth. So pain is not related to the teeth, but even to the surrounding structure. And it's a sharp jabbing type of a pain. Whereas a TMJ disorder, you can have a locking of the joint, clicking sound while opening, or a jaw deviation. Now, here I would like to tell that our patient, we have done a treatment, lower 7 C-shaped canal done by the postgraduate. It was his first case, so she took more time to do the obturation of the C, and even she extruded some of the amount of sealer beyond the apex, because it was single canal C type, So that patient had a lot of pain post-operatively. So we were relating it to the extrusion of the sealer. And the PGs, we were believing that this sealer is the reason why the pain is so much, and we were planning to go for the surgery if the pain is not decreased. Fortunately, unfortunately, I took the same patient to the oral medicine department, and they have taken the multiple x-rays and examined the patient. It's because of the prolonged opening of the mouth, that 2 or 2.5 hours, he had a locking of the jaw. So his jaw was getting locked, and so the pain was more into the temporomandibular joint. So they advised them the treatment, and the medicines were given, and within 10 to 15 days, patient was normal. So we avoid some unnecessary treatment by doing a correct diagnosis. Now, rather than we all are always, easy for us to diagnose the caries and the reversible pulpitis, irreversible pulpitis, necrosis. That all conditions are okay. But most annoying, another condition is known as a cracked tooth syndrome. Now, clinically, we see two types of crack. Either it's a complete crack or it's an incomplete crack. The complete cracks are very easy to diagnose because clinically it's visible. You can see the splitting of tooth, or sometimes the piece is mobile. But for the incomplete cracks, they are challenging because the patient's pain will vary from the mild sensitivity to the pain on chewing, to the tenderness on percussion, and even more. So here is, I have mentioned the various type of tests which you can use, like clinical examination, percussion, transillumination. But according to me, the top priority here is a magnification along with the methylene blue dye test. So now methylene blue dye is also available in the ready-made syringe from the new Endo. So you can buy that, take an applicator tip, apply it on the area where you are suspecting the crack, and then wash it after a minute. Observe that same tooth under the magnification at 10x or a 12x, depending upon the magnification. Most of the time you will get the crack if it's an incomplete. And then depending upon the extent, we need to do the treatment. Very rarely you even have to go for exploratory excavation. That means that if you are suspecting that the crack is present below the large restoration, we may have to remove this restoration after taking patient's consent, and you will see the crack. Now, if this crack is present and or a patient will give you a history that that it is because of biting some hard nut. Yesterday, I bite some nuts and this tooth got cracked. It's still easy, or it is, I said, limited to 1 or 2 teeth. But if it's chronic cracks or multiple cracks because of the parafunctional habits where more teeth are involved, those patients really require more attention, because today, if you treat one crack, after 4 or 5 months, he'll come with another crack in his mouth and extending deep, and the tooth will gradually will undergo necrosis. So here you require an interdisciplinary approach from the ortho people. Even there are some physiotherapists and prosthodontists who can help you out in dealing with this case. Another condition which I always see that they are missed by my postgraduates as well as by my junior faculties is a trauma from occlusion. Its name itself suggests it's a traumatic occlusion. So the occlusion forces to the periodontium are much more than the tissue can bear. And such type of condition will lead to the gradual destruction of the periodontal ligament, and along with that, the bone. Now, if you have this classical bites, you know, that single tooth is coming in occlusion, or a flare teeth, this is most of the time it is ignored, or a severe bruxism, we will still be able to understand. According to me, most of the people do not see only the bite, how the patient's bite is, whether it is occluding properly or not, or whether because of the destruction, the restorability of the tooth is there or not. This is also one of the very common finding. We just start the treatment, and after the treatment, we realize that I cannot restore this. One such example is one of our own student appearing for the exam, and he has shown or approved his case last moment radiographically. The faculty approved. It was indicated for the post-encore, no doubt about it, but bite was not evaluated. So at the end, because always when the opposite tooth is, it is fractured, the lower tooth will try to supra-erupt and take up the place. There was actually no space even for the core buildup, sufficient core buildup, forget the crown. So such thing will happen. So please evaluate your bite before you decide any final treatment plan. So coming back to this condition, here, the traumatic bite will lead to the widening of the PDL space as well as the angular bone loss. So classically on the radiograph, you will see that the tooth which is in traumatic bite will have a more bone loss in comparison to the adjacent tooth. So this will indicate you that there is a trauma from occlusion present. I also have many students who will come to me and they will say that, Madam, this canine is paining since 15 days and the pain is increasing. Pain is continuous. if you have such patients who are, or students who are visiting to you, just ask them whether they have undergone an orthodontic treatment previously, because most of the time it's a relapse from the ortho treatment. So you just do occlusal adjustment, send that person back, call him or her after a day or two. If the pain is reduced, that means it is because of the relapse of the ortho treatment. We need to send the patient back to the orthodontist. So now we know that we are in an era of 3D imaging systems, and CBCT are being used extensively in endodontics. So we are advising CBCT whenever we have a doubt about a particular case. So request to all the faculty members and colleagues that please follow the American Association of Endodontic guidelines for recommending CBCT in endodontics. Just do not advise haphazardly. Number 2 is please be aware about the field of view. Because for endodontics, we required a limited field of view, that is only an arch, that's a 5x5 or 6x6. So this field of view will not only reduce your radiation exposure, which is equivalent to 4 to 5 IOPAs, it will also give you more sharper image. So this is more important for us. When I'm advising a larger FOV CBCT, the spatial resolution is comparatively poor. So I don't get a sharp image. So lower FOV CBCT will allow me to give a sharp image and that clarity which we actually required for endodontic diagnosis. So please advise limited FOV CBCT, because I myself has received one endodontist advising them for himself a large FOV CBCT with 2 millimeter of slice thickness, which is absolutely not needed. You require limited FOV with 0.5 or 1 mm slice thickness, that is sufficient for us. Even though this is also another observation that we are not aware, or we don't ask the student that whenever they are showing a CBCT, which section CBCT are you talking about? Please ask them, because they are not aware what section of CBCT they are showing. Because eggshell is very easy that everybody said because it's a cross-sectional horizontal. But when it comes to the vertical, we have two. That's a coronal, which is anteroposterior section, and the sagittal, that is a lateral section. So whenever they show you a CBCT, please ask them that which section are you talking about? So we should also reinforce this thing so that they are aware, okay, this is a coronal section and this is a sagittal section, which is a lateral section. So another common point which I want to recommend to each and every one of you is we want our CBCT to be totally artifact free. You know, the artifacts are of many types, but the one which affects us most commonly is known as a beam hardening. Beam hardening is a white and dark streaks which is seen around the radio-opaque substances. Now, if patient is has come to you for the retreatment, and if he or she is having a post or a metal restoration or a crown or a gutta perca or a metapex, then these all are the radio-opaque substance. So along with that, you expect a dark or a white shadow, as you can see into this figure. And this will give you a wrong diagnosis, like the black line which is present next to this radio-opaque obturating material. It's not a crack in the tooth, it's a beam hardening. Similarly, the hollow space which is seen next to the post is also beam hardening. So to have an artifact-free image, before you advise CBCT, please tell your students or guide them that there should not be any radio-opaque substance. Of course, in some cases, it is not possible, but whenever it is possible, please remove all of them, make your canals empty, and then you send the patient for CBCT. Another point is I am highly recommending that we should, as an endodontist, should do evaluation of our CBCT using a DICOM files. Please do not rely on our radiologist or the friends who are in the radiology department. There is no doubt they are much more competent in diagnosing the CBCT than us. But when we are dependent on them totally, we are not using the CBCT to its highest application. Now imagine I have one patient who is having a resorption, the root part of the tooth, which is near the cervical region. So like, I will check first, evaluate the patients clinically, So I know the clinical signs and symptoms. Then I know the treatment option. So based on my CBCT, I will see whether this lesion is above the bone level or below the bone level, or part of it is above the bone level or below the bone level. What is the size of the lesion? So if it is below, I can feel it under the magnification with MTA. If it is above, I need to reflect the flap and go for corrective surgery. If it part is above or part is below, my treatment part will be different. So if I have to advise various treatment option to the patient, I have to be more sure about it. And I am going to treat the patient. So my size instrument, what length instrument I need, what I can measure everything. I can, what instrument will actually allow me to go inside. So everything is possible if you can do a measurement, and even a possible danger. I am very much well aware about the possible problem I'm going to face. So I can also keep my plan B, like an oral surgeon next to me, if I feel that there can be a problem, or he can be there as an assistant to me along with the treatment. And if you want to use the 3D models and 3D guides, believe me, you need to communicate so much to the lab, that what is the size of your burr, how much depth you are going to insert, and how will you take the approach, so etc., or what you want them to do. So those things are only possible if you are doing a diagnosis in your own way. So here I'm sharing you some cases which we have used for the treatment planning and helped us in treating many conditions. So here is a very simple case, looks very nice on the IOPA. And if you see on the palatal side, there was a radio opacity. This was in a sagittal section, tooth was evaluated and the missed canal was treated and the lesion healed. Another such patient is, this patient was referred to us for the treatment of, fractured instrument. That doctor said that there are two hard metallic structure in the mesiobuccal and the distobuccal root, so please remove them. Whereas when the CBCT was taken, the pathology was in relation to the palatal root. So we did not touch this visual root at all because they were asymptomatic, because it could be a silver point feeling, I don't know. So we didn't touch this, only treated the palatal root, and the patient is absolutely okay. Third such condition is, this was a root canal treatment done on the premolar, and the new all ceramic bridge was given, but patient was having a continuous pain in relation to this tooth. And this pain was particularly, it was a discomfort and more pain on a chewing. When everything was looking absolutely okay, we took a CBCT, and this is what the sagittal section is showing, that the radio-opaque material extruded beyond the opaque. So this could be one of the reasons that that patient will have a mild discomfort because it is continuously irritating. Another point was the root tip was out of the bony socket. So this is what we call it as an apical fenestration. Now this type of apical fenestrations are present in relation to maxillary canine and premolar, because maxillary bone is thin in this area. So root tips are out, and in most of the cases, they do not cause a pain, but sometimes after the root canal treatment, because of the continuous irritation, this will give you a pain. So such pains are not severe, but they are continuous, dull, and mainly aggravated on the chewing. So you don't have to do anything, just remove this, do apicectomy and put this bony root tips well within the bony socket. We have treated around 4 or 5 patients with this apical fenestrations, and they are doing all well. So another patient with the difficult anatomy, this was an IOPA of the patient with a double invaginatus, if you can appreciate over here. Of course, when you see such anatomy, the first thing you do is you advise CBCT. Now, believe me, in this case, CBCT has also not helped us. It has also not solved our confusion. The one question which we had from the first day is whether this radiolucent area, which is present below the invagination, is a part of a tooth or it's a part of periapical tissue. Because my treatment will be depend on that. If it's a part of the tooth, I need to seal this orthodontically or orthogradely, sorry. And if it's a part of a periapical tissue, I need to do surgery and remove the granulation tissue from this area. So, dear friends, we spent around 1 month. We have sent this CBCT to many radiologists. Because if you can appreciate, in one section, it is seen as it is well within the tooth area, a tooth end case, whereas here it is open. So then at the end of 1 month, one person from Hyderabad who is into the 3D printing has contacted us, and he said that this is a part of a tooth. He sent us this 3D model, and even we asked for the cut sections. So then our treatment plan, we have planned the treatment and been executed. But it was not easy. As you can see, I even had to go for guide because it was 3 opening with the 4 canals in this tooth. Plus, if you appreciate over here, there are, after middle portion, it's a circular area. So treatment execution and planning was required at every stage. I cannot rely on only cleaning and shaping with the rotaries or a circumferential filing. I need to rely more on the irrigation, because my remaining dentin thickness in some area is very, very low. So what size of instrument I should use so that I can get entry without undermining the walls? What size of instrument will help me to condense empty at the apex? So all these problems, stage by stage, performing each step every time, we have solved it. Unfortunately, this is in a publication mode, so I will not be able to show you the complete case, but finally we came to the result, and now the lesion is already healed. Another condition is a lower 7 with the C-shaped canal, and it's having an apical trifurcation. So here you can see on a virtual model that to bifurcation, this was very easy to diagnose, whereas the third one, which was on the mesial root, and it was at the angle which is slightly above your apical exit. So this was the challenge. So we can always imagine it's a lower 7 having a single C-shaped canal and an excess getting on the mesial wall that is at that angle. So this was a challenge. And when we were initially working with our hand files only, our hand itself was blocking our view. So you have an option of using a micro opener and micro debrider in this case. But of course, in the institutions, we cannot afford to have such a high-end instrument. So we have used something called as a canal handle. This canal handle is around 800 to 1,000 rupees instrument. You will get it online. Here, if you attach your K file, it becomes a micro opener. And if you attach a H file, it becomes a micro debrider. And finally, we negotiated this canal and the treatment was completed. So with this, I'll come to the next part, that is a vital pulp therapy. Now you know the minimal invasive endodontics and vital pulp therapy era is going on. So a lot of emphasis is given on preserving the pulp and preserving the surrounding dentine for the long-term survival of a tooth. So the rationale for this vital pulp therapy is mature pulp has a greater regenerative capacity than previously thought. So if all or a part of the pulp, if we will preserve it, the process is less invasive, it retains a biologic immune response and lead to the healing and prevent infection to periapical tissue. So now there are a group of scientists, it's an article by Walter et al. There is a group of scientists who are against the terminology irreversible pulpitis. According to them, there are 2 types of pulp. It's an inflamed pulp or an intact pulp. So inflamed pulp, if you remove the remaining intact pulp, is resilient and it has all the chance of healing, and we should allow this pulp to heal. So they have proposed a new classification, and now a lot of studies are going on. They are discouraging the term irreversible pulpitis. So according to them, the new terminologies is initial pulpitis, mild, moderate, severe, and pulp necrosis. So clinical signs and symptoms for each conditions are also mentioned, even a histological findings and the proposed treatment. So such classifications or a terminology like irreversible pulpitis, we may not have after a few years. So now the question is why this paradigm shift has happened from previously when we were treating all irreversible pulpitis cases with root canal treatment. Now why this sudden change? So it is by Dr. Rikuchi in 2014. His histological studies have stated that in case of pulpitis or irreversible pulpitis, the inflammation is limited to the coronal part of the pulp only, whereas the radicular pulp is totally intact, and this pulp can be preserved. Now, when the treatment proposed for irreversible pulpitis root canal treatment, it was an era of 1955 to 1960. Now, at that time, the material what we were using for the pulp capping and the pulpotomy was calcium hydroxide. Now, calcium hydroxide is an excellent bioactive agent. It has a healing potential, but it's lack in a sealing ability. It is having extremely poor sealing ability. Whereas the material what we were putting on top of it was an amalgam. Amalgam is also having a poor sealing ability. So when I am not able to seal that lesion properly, ultimately micro leakage will happen, and so the tooth will gradually undergo necrosis and so failure. So that's why the RCT was proposed. But nowadays we have a material like an MTA, biodentine, and second generation pre-mixed bioactive putty agents. They have antibacterial property as well as a good sealing ability. And on top of it, when we do it with either hybrid ionomer or with the composites, they also bond very nicely with the tooth. So that's why the success rates are being observed. So friends, if you are planning to go ahead with this vital pulp therapy, there are 3 or 4 points which I want that you should always take care. Do a proper diagnosis and case selection. For that, I would request we should refer to the European Endodontic Association guidelines for the deep caries management. They are excellently described each and every terminologies and what we should do with each and every case. If you are planning to move ahead, then maintain absolute sterility throughout the procedure. This is absolutely important. The sterility should be like as if you are performing your surgery. So each and every instrument, burr, eroded handpiece, everything should be autoclaved. As we have discussed previously, the microbial contamination can be the reasons for the failure. So we cannot afford to have infection when we are performing this procedure. So normally in my department nowadays, we have a 1 or 2 sets every day ready strictly for this vital pulp therapy cases, because these cases are such that they are walk-in patients. Patient is having pain, severe pain, and I'm planning to do coronal pulpotomy. So these sets are separate and they are autoclaved, and separately they are being treated. Third is a thorough cooling of the pulp. So your aerator spray should have a copious amount of water. It should spray effectively so that pulp will not get heat up. Because if it will get heat up, it will undergo necrosis. And this problem is more if you are treating a premolar, because premolars are having very narrow chambers. So in this case, you can also add an additional saline or a water, distilled water, and keep the pulp cool. And third is use a sharp burrs. Don't use the blunt burrs so that it will cut the pulp very effectively. So using this technique can be beneficial because it's a less invasive. You can save the tooth structure and ultimately increases the tooth life. Time and the cost of the patient and the discomfort also you can avoid. And I would say that a lot of armamentarium which we require, extensive armamentarium to perform the endodontic treatment, can also be reduced. And we can always take a help of biologic response of a pulp. Now, moving one step ahead to this is by our Dr. Ajay Logani, sir. He has given a concept of endovital therapy. There are articles in the Journal of Endodontics where sir has done a randomized control trial and shows a success rate. So sir has moved one step ahead and he has recommended that if in the vital pulp therapy, or if you open up the pulp chamber and if you observe that part of a pulp is necrosed and only part is vital, please treat only the necrosed part and preserve the vital pulp therapy. Even now, you may have seen this half root canals, and this is not new. We need to accept this because maybe in future we will also start doing the same. So now I have done my proper diagnosis, I have done my CBCT evaluation and decided that this tooth will go for root canal treatment. So the first and the foremost step is a pre-endo buildup and the rubber dam application. Now these two are the most ignored part. Whenever I have seen even endodontists doing a treatment. But these are the two most important part according to me before we start a root canal treatment. Now, what are the advantages of doing a pre-endo buildup is it simplifies your rubber dam isolation procedure because you can get contaminant-free surface only if you have converted this class 2 lesions into class 1. It creates a space, a function of irrigating solutions like sodium hypochlorite. So when I'm using the sodium hypochlorite along with the agitating devices, they should have a space into which they move. Otherwise, they will come in contact with the gingiva and patient might have a multiple ulcers or even some reactions because of the sodium hypochlorite, because I need to use a high concentration to get a more disinfection. So this is extremely important part. Another is it even allows an effective inter-appointment temporization and prevent a bacterial micro-leakage and seepage of intracanal medicaments, prevents fracture of the weakened tooth structure, and helps in maintaining repeatable reference points. It also improves aesthetic of the patient, particularly in anterior teeth. This is more important, and even facilitate post-endodontic restoration. Now, the most annoying part in this buildup is managing this bleeding gingival tissue. So here are some methods by which any of this you can use. Is, of course, you have a soft tissue laser. It's a very effective and easy method. Second is you can use an electrocautery if you are not having an access to laser. This is another economical instrument. Third, this instrument is sent by one of my passed out PG. It's an ophthalmic microsurgical knife. Her husband is an ophthalmologist, and she used to assist him in the cataract surgeries. So these knives are around 30-35 rupees one knife, and this knife cuts this gingival tissue very sharply and effectively. So this one knife, you can use it for nearly 3 to 4 patients. So this is another recommendation. If you have attached medical college, we can always get from those medical college and use it. PG's most favorite is hot punisher. Yes, but even you can use, it will blanch the gingiva very effectively, and thermacut burr if you have an access to this. So now when we are ready with the buildup, the next step is you have to go for the rubber dam application. According to me, there is not a single tooth which cannot be isolated. Whatever you say, every tooth can be isolated using a rubber dam. And I feel it is without that, we should not even start root canal treatment. And this is now becoming more important when we are talking that we are working under the magnification. Because when we work under the magnification, our patient's position is mainly supine position. And we are at 9 o'clock or a 12 o'clock position. So at that time, you can imagine that whatever we put in the patient's mouth will directly go into the throat. So it can cause a lot of harm to the patient. So when I talk about magnification, and I hope that everybody is using a magnification, then it is there cannot be a dentistry without a rubber dam. So it is also a sign of a quality practice, and we can avoid many medico-legal issues in future. So I am not going to tell you that how to apply a rubber dam, because most of you are aware about how to do a routine rubber dam application. But there are some cases where we have a difficulty, like a partially erupted tooth. So because this clamps are taking anchorage below the height of the contour, the partially erupted tooth is a problem, or even a short crowns in those cases. So we have a lot of issue of popping out of clamps in this case. So here you can use one technique which is known as a composite button technique, which you can see in this green rubber dam image, that the two composite buttons are edge bond and kept, and the clamp is applied below that. So if it will pop out, it will get stuck at that stage, and total pop out will not happen. Another point is you can use an apically directed clamps. This is from Euphridi, and or a Brinker's clamp, that is from any of the Brinker's clamp, the wingless clamp, because wingless clamps are they are having an apically directed jaw. They take support from the root of the tooth, right, from the apical directions. So these clamps will give you more deep anchorage, and you can solve your problems of popping out. If patient had an orthodontic treatment, of course, if only the orthodontic brackets are placed on the teeth, the simple quadrant isolation, because rubber dam is having sufficient tensile strength that you can stretch it and put it over. But if the patient is having along with the wire also, we can go for split dam. For deep class 5s, you can go for Style Italiano B4 and B5 clamps. They are the excellent clamps with this. Next question is, if my adjacent tooth is having all ceramic crowns, the rubber dam will crack the ceramic. So here, you can either use a ready-made cushies. They are not available in our country, but if you have an access to that, you can get it from the Western countries and use this. Now, when you are not having an access to this rubber dam cushies, you can also create your own customized cushies. So what you can do is you can apply a light body rubber-based impression material on the prongs of this clamp, and then allow it to set, and then the same assembly, you can take it on the tooth. It will even help you to seal, get a good sealing between the clamp and the, your rubber dam sheet. So you don't require a damp seal material later on. Some are using this plastic clamps also because they are also not so sharp. These plastic clamps are even recommended when you are doing some canal negotiation or canals are having calcification in the cervical part of the tooth, because metal clamps will interfere in your radiographic interpretation. So these clamps are specifically indicated for these two conditions. Or you can use a clamp over a dam technique when you have doubt that you might crack the adjacent tooth. So any of this technique you can use. For a tooth which doesn't have any tooth structure, for anterior, you can maxillary, you can go split dam. And for the crown prepared tooth, definitely you have to go the posterior quadrant isolation technique. There is another technique for molars, which is known as a canal projection technique. All of us are very well aware about it, but I have not seen people practicing this technique. Believe me, this is very convenient technique. You do excess opening and enlarge coronal portions a little bit, and then apply a rubber dam. Then you do a build up and apply a rubber dam for the next of all your appointments. So once you do apply a rubber dam, please do dam inversion, because it gives a very nice clean feel. The fields are so beautiful that you will love to see your work. And do a floss tie when you are expecting a subgingival conditions. So now, since second year, we are teaching to the students that you have two types of clamp, winged clamps and wingless clamps. Of course, we all know about it. So again, not going actually into the detail of it, but wing clamps are the most common clamps which are used. Around 85–90% of the work is done by the winged clamps. But and why they are used so extensively? Because they are easy to use, they are recommended for beginners, and they have this horizontally directed jaw which take anchorage below the height of the contour, and they will give you a stable isolation. But in cases where you have a disto-occlusal class 2, like lower 6 DO, here there is a problem, because you will apply a clamp on the 7 and it has this horizontal jaw. Now imagine you are using a Pallodent matrix system or a Garrison or a BioClear, whatever. So that wedge and the matrix then assembly will not have you will not have a space to put this assembly, because the horizontal part will interfere in the placement of your band and the retainer. So here is a challenge. So this is a limitation. Similarly, in deep class 5 restoration, partially erupted tooth and molars, as I said, they take anchorage below the height of the contour. Prepared crown sometimes, and when the patient is having a thick buccal pad. So here you can always shift yourself to the wingless, because the wingless clamps are also known as a special clamps. They have a special indication, as well as they are also known as tissue retractors. So they retract the tissue more. And they have an apically directed jaw. They engage in the most apical part of the tooth. They are more retentive, as well as they cause a less endurance. So whenever you cannot get isolation with the winged clamp, please shift yourself to the wingless one. Now, another clinical point which I want to add over here is, if you are treating a primary endodontic lesions, we will directly start a routine procedure after the rubber dam application. But suppose you have to remove some old composite restoration, which is a deep carious lesion previously treated by someone, or you are doing a re-root canal. Now, we all are aware that today's dentistry is known as a biomimetic dentistry. Now, everybody is restoring dentine with a dentine color shade and enamel with the enamel color shade. We literally make the restorations totally invisible. So you can imagine that whenever you are removing this, if you will not remove these restorations carefully, you will even cut the intact dentine. And ultimately, we will end up doing the weakening of the tooth structure. So here there are some tips so that you will not touch the dentine, and you will touch or remove the composite part of the restoration, composite part only. So first and foremost in this is a high magnification. This is always on a top priority, because magnification, when you are working, it will make it easily you can differentiate which is a composite and which is a dentine. So it will be easy for you. You can even switch yourself to the slow speed, or you can reduce the speed of handpiece and you can remove that. Second is the etching with 37% phosphoric acid for 15 seconds. The composite will look more opaque and more frosty. Same thing you will observe when you treat the tooth with the isopropyl alcohol. So any of these two, when you use, the composite will be more frosty and the dentine will be look more dull. So it's a clear-cut indication. Use Explorer, Sharp Explorer. So composite will have a scratchy feeling than the tooth. You can also use an aqueous solution of methylene blue dye. Now, this methylene blue dye, you can apply on a area where you have a doubt, wait for half a minute, wash it out. The composite will take up the blue color, whereas the dentine will leave the blue color. So the stained part is a composite. So only remove the stained part. And this method is very effective. Even we have done a study on it and it works excellently. And of course, you can use a laser, but hard tissue lasers are not accessible to everyone. So next part is, if somebody is referring a patient to you and he or she is your friend or a prosto, or you have done a crown, and after some time patient will come back to you and say that I'm having a pain. So now I don't want to remove this crown because we have charged heavily to the patient for the ceramic crown or a bridge. So when we have to do access through the all ceramic crowns. Now I'm here only focusing on all ceramic crowns, because how to remove the metal crowns and PFM crowns is since all these years we are doing it. But it is different from the removal of ceramic crowns, or cutting through the ceramic crowns is different than the metal crowns. So always we have to remember at this time is that the main purpose of doing getting access through the crown is I need to preserve my crowns. So my ceramic crowns should not have a cracks. You know, the ceramic is a very brittle material. It can easily undergo crack, and if it will undergo crack, it will fracture also. So we want a crack-free entry through the ceramic crowns into the root canals. So here for that, we have a DuraCut burrs. These are the special purple ring burrs from the Bresler, the same company which is producing endosequence sealer, BC sealer, is the same company who is marketing also this DuraCut burrs. They have they are diamond points only, but the diamonds are more firmly bonded and they have a more surface hardness. So what is the how to use this burr is we don't enter into the crowns like as we are doing an excess opening. You don't have to go deep. Rather, you have to use a brushing motion like a sandpaper. So gradually you swipe it out under the force and step by step you go down. So this the main reason for that is there should not be any heat generation. So this procedure is even done under the presence of copious amount of water, because it's a hard metal versus ceramics. So if there will not be a water, then this can undergo a there will be spark creation, and this spark will lead to the crack formation in the ceramic. So go slow, go sweeping motion, don't go depth-wise cutting. So it is preferred to have a shallow cutting, and gradually step by step you can go down, and in this way you can get entry into the all ceramic crowns into the root canal. Now this is a new trend, and I think it is getting popular day by day, is electric handpiece versus our aerator handpiece. Now in all this year we are using an aerator handpieces, but now there is something called as electric handpieces which are available. They are much more beneficial than our aerator handpiece. So let me share that what are the inherent disadvantage of the aerator and how they are managed in the electric handpieces. So aerator handpieces, we know that they have a distinct noise and a vibration. And this noise and vibration cause a lot of discomfort and increased stress level to the patient, particularly those patients who are very much anxious or having a lot of anxiety or fear. We even observe that there is a change in the speed. If I give some pressure, the speed will change. So, because of the resistance which is built up. And reduced torque level, it will lead to uninterrupted cutting efficacy and lot of aerosol production. Whereas the electric handpieces are having a wide range. So you can use it from 75,000 RPM per minute to 5 lakh RPM per minute. So it has a main advantages. It has all these speeds. Now, gradually, we are moving in an era of a minimal invasive dentistry. Our crowns are also now being replaced by the partially bonded restoration, inlays, onlays, overlays. So we have to focus on cutting less. We don't have to focus on cutting more. So when I have to cut less, my speed should be adjustable. Eroters are more or less, they're cutting at one constant speed. And this is the major limitation. We end up doing an over preparation. So electric handpieces are preferred because of the bonded dentistry. So they provide a constant speed and torque where it does not change as the load increases, and they create smoother and precise cut and give you more flexibility because it has a range. It do not produce noise and do not give vibration. So patients are also comfortable, low aerosol production, and they have a changeable rotational speed and adjustable speed. These are the basic advantages. Of course, nowadays they are expensive. You have from NSK now, the new endo has come up, but I feel gradually over a period of 1 year or so, they will be available at comparatively rate where we can all afford it. So the next concept which I want to emphasize is on the restorative driven endodontics. Now, this concept was basically given to avoid the complications of root canal treatment or post-operative sequelae of the root canal treatment. We all, even that includes me, whenever any patient will come to me for the root canal treatment, what I used to do is I will start root canal treatment, access opening, cleaning, shaping, obturation, post-endo, and then what is given is a crown. Because the crown was most of the time was a post-endo restoration, except some conservative class 1 where we fill it with a, fiber reinforced composite, or nowadays since 2, 3, 4 years, we have started working with endo crowns. But what problem is happening is when the scientists have evaluated the outcome of the root canal treatment, they realize that the failures are happening more because of the fracture of the tooth. Now, this fracture of the tooth is because of the excessive preparation, that excess openings, and the root canal preparation, that because of the greater taper files. So when these things are happening, the fracture rate is high. So they have given a concept of this restorative driven endodontic. That means before you start your root canal treatment, think about which post-endo restoration you can give in this condition. So based on that only, you do your preparation. So they say they have given a concept of caries-driven excess. So how much ever caries is there, you remove that part, or orifice-directed opening. Do not touch the intact part at all. And so you have to give a post-endo restoration also based on that. So because we are long-term success of the natural tooth is only we can expect if the more amount of tooth structure is preserved, and that is particularly the crucial pericervical dentine part. So restorative driven endodontics has a 4 major part. It's a conservative access, use of variable taper nitri files, hydraulic condensation technique using BC sealer, and partially bonded restoration. We'll cover each one of them. So against the traditional excess, the caries or orifice-directed access. So what do you mean by orifice-directed access? It's now because we all are at least working with loops, that's what we assume, or a magnification. We have an easy access to the internal part of the canal. Our vision is very clear. So that's why in this case, when I am my mesial canal is accessible from the distal side and distal is from the mesial side. And we have now endoguide burrs from the SS white. So these burrs are very needle-shaped burrs and very precise burrs who help us to locate the orifice and do a coronal enlargement. So when such facilities are available, I can go ahead with the caries-driven access against my traditional straight line access. And so I'm preserving more amount of tooth structure. Similarly, for anterior teeth, rather than taking an approach above the cingulum, the canals are always located slightly lingual to the incisal edge. So if you enter straight, you can get access into the root canal, and this saves also a lot of amount of the tooth structure. Second part is using a variable taper file. Now, the constant taper file, as we know, they have a constant taper. So they remove more amount of dentine from the cervical part of the tooth. Whereas variable taper files are having a taper only in the apical 1/3. The coronal part of those files, either they are having no taper or they have a less taper. And because of that, the less amount of the tooth structure is removed. And these files, because they have a less bulk, they are flexible also. So you can use it in the very narrower canals, or you can end up doing the narrow preparations of your canals. And the last portion, last part of this is use a partially bonded restoration. So the concept is restore only what is lost with the minimum preparation. So you think about this, you see the caries lesion. For example, if it's a lower 6 and the caries is present on the mesial side, do not extend at all on the distal part or even on the middle part. Don't start with your access opening traditionally from the central point. You can always start from the caries, remove only the portion which is infected, restore them with either a half inlay or a inlay with a cuspal coverage, and that's all. I think we all know now biomimetic dentistry. Create a good biobase and restore the enamel part, what is lost, with the indirect Emax restoration. So that concept is very much popular. So all this, you can go for inlay with cusp capping, you can go for overlay, you can go for occlusal veneers or endocrowns. Any preparation that will preserve your cervical part of the tooth or a cervical dentine, that should be recommended. About the glass bioceramic sealers, I'll take that part later. So we'll cover during that part. So after the access opening, now you have a new concept, like an immediate dentine sealing. Now they call it as an immediate endodontic sealing. So as soon as you do access opening, please seal all your canals. Like an IDS, your access chamber should be sealed by the filled bonding agent. The protocol is same and the concept is also derived from the IDS. Now, why we need to do that? It is said that it is studied in vitro studies has been done, and they have come with the conclusion that the high concentration and long exposure of this sodium hypochlorite has a proteolytic and deproteinizing effect, and they damage the collagen layer of the dentine. And this ultimately hinders in a formation of consistent hybrid layer and results in a poor bond strength. The sodium hypochlorite also breakdowns in the sodium chloride and oxygen, and this oxygen will interfere in the resin polymerization. So that is why if you can see this two SEM images, the one which is having a differentiating line is a delayed endodontic sealing. So the endodontic sealing was done finally after the obturation. Whereas where it was done immediately, you can see a consistent hybrid layer formation. So there are very few studies. I could only find one, if I am not wrong. So this is even I'm sure many faculties are interested also in doing a study and exploring these facts further, that how much difference in the bond strength we get when we do immediate endodontic sealing and delayed endodontic sealing. So this concept is worth accepting because IDS success we have all seen. So very basic terminology next I want to explain it to you is because this was even a confusion to me before a few years. What is scouting? What is glide path? Because people use this term interchangeably, and you know, I feel it's the same. I was also feeling it's the same terminology. Okay, some are using the word scouting and other are using the word glide path. But believe me, there is a clear-cut difference. And when I came to know about it, I was even shocked. So the scouting literally means it's an action of gathering information about the enemy forces or an area. So apical scouting literally means gathering information about the apical 1/3 part of the root canal, which is for us, it's the most crucial part of the root canal. So it helps us to know how my canal exit, merge, dilacerate, curve, or a recurve. So when I insert my file and I came to know that it is distally angulated or mesially angulated, that this information is known as an apical scouting. So normally it is done with the hand files along with your tactile sensation. So second part is scouting is done always before the treatment? Not necessarily. Here is a case. So scouting can be done before or after. So the master cone, entire preparation was done, master cone was selected, but then when the recap was done, but the file was introduced in some another direction, there was a catch. So when this catch was explored, we realized that it's in bifurcation. So scouting can be done before and after your preparation. We know Dr. Jaydev is even our own very young guy. He's scouting the lateral canals also. So scouting is something which we can do before or after. So it will basically give you information about apical 1/3 part, how acutely it is curved or gradually curved, or it has a double curvature. And normally we use stainless steel file for this. Whereas the glide path on the other side is a series of event or action which lead to a smooth particular outcome. So endodontic glide path is a smooth radicular tunnel from the endodontic orifice to the physiologic terminus. So glide path, we can use hand as well as rotary files. Both can be used. And the main importance of glide path, it will help us to mind map the 3D anatomy of the root canal space, and it will increase the average life of the night eye rotary file almost 6 times, and chances of separation and ledge is also reduced. So glide path of a normal or a large size of file is large size of canal is very easy. But when it comes to narrow tortuous canal, we always shift ourselves to C+ file or a C pilot files, right? So what is this C+ and C pilot files? How they are different from your normal traditional stainless steel files? So everyone, we also asked the student that why you use C+ files? So we said the buckling resistance is good. But what is this buckling? Buckling literally means it's an elastic deformation of an endodontic instrument where they're subject to a compressive load. So when I'm pressing my file, it undergo elastic deformation. Now the word itself says that means when I'll remove the load, it will come back to its original position. So the buckling resistance is good. That means if I am giving this apical compression and then removing it, the file will come back to its position. Along with that, it also has an active tip. So this active tip and its metallurgy is also slightly different because of the heat treatment. It is more stiffer and stronger. So that's why we are using it more effectively in the narrow and the calcified canal. Whereas a stainless steel file, as I've shown you in the previous slide, will have a plastic deformation. So that is what is called as a kinking of the K file. So K file will kink, your C pilot file will have a original shape. So now the next part after this is ultrasonics in endodontics. Is it necessity or a luxury? So if you ask me this question before 10 years or 1 decade, I would say that not needed. Only we use ultrasonic scaler to remove calculus for the study purpose of some in vitro study we are using in the department. We are actually not using. But nowadays, I want that each of my dental units should have an attached ultrasonic units. The simple reason is the magnification. Because of the magnification, we have started troughing and accessory canals, lateral canals, mesiobuccal canals, MB2 and middle mesial, etc., etc. So ultrasonics has all these uses and even much more than that. But because of the magnification, now we have started troughing. And this troughing is done either with your ultrasonic files or with the long shank burrs, like your Munz burr, or you have now endoguide kit. All these are used for the troughing. So there are some tips. So I just want you to know, at least we should know that which tip is used for what purpose. So there is something called as an active tip and smooth tip. So active tip means which has the cutting efficacy. Now this active tip could be diamond coated or it could be like a burr. So it's a fluted. So, but these tips are actually used for the cutting purposes like a removal of post or your troughing through the calcified pulp stone and getting actually into the canals through calcification. So these are cutting tips. So, but they can be only used when you have a good view and low risk of creating iatrogenic injury, because they are fast cutting tips. Whereas the smooth tips, they have a limited cutting efficacy or no cutting efficacy. So they are used for activation of your irrigans or a condensation of gutta percha, etc. Another one is the nickel titanium tips and the stainless steel tips. Of course, nickel titanium tips are used when you have to remove the instrument from the apical 1/3 portion. They are more flexible and more fragile as well. So we have to use them in a very low frequency. Now, otherwise also the ultrasonic tips, when we are using in endodontic purpose, we know the latest ultrasonic scalers have a two function, the perio function and the endo function. So perio functions are having more frequency and endo functions are having less frequency. So if you have a ultrasonic scaler which has a two designated function, it is still okay. But like if you have a simple satellite P5 booster which doesn't have this designated frequencies, then I would request that you have to use it a very low frequency. Like for scaling, if I'm using 8 or 9, here I cannot go more than 3 or 4. The simple reason is if you use a high frequency, you will end up having a more fracture of files. And remember, these ultrasonic tips we are using inside the canals to trough the isthmus area, to get a middle mesial. So they are very precise work. So when I have to do precise work and controlled cutting, I have to use a speed which is in my control as well. Another is a diamond coated tip and non-diamond coated tip. It is same as that of the active and the passive tip, but most of these diamond coated tips are used without irrigation. So they tend to get soiled with the dentinal debris. There are special tips which are also available for isthmus. So this is only for the activation of irrigants in the isthmus area, that is E18 isthmus. If you want a cutting action in the isthmus region also, like a middle 1/3 apicals, after middle 1/3 the canal is split, or the apical 1/3 the canal is split in the premolars, you can use E18D, that is isthmus diamond. Isthmus conical, which is shallow one, and use when you have a more superficial separation of isthmus. And the last is a flatsonic. Here they are used in a deep area where you can expect a canal sometimes. So there you should use. So here I have mentioned in very brief about the exact protocol of how to trough your middle mesial or an MB2. So because this should be a routine for every case. Now it is recommended that we should try to trough for the middle mesial canal or an MB2 canal, because most of the time they are present, particularly when you work with the magnification, you will get it. So for that, I would request that first you allow the student or guide them to prepare all the canals, main canals, your mesiobuccal, distobuccal, mesiolingual. Tell them to prepare the main canals and then flush the entire chamber with the liquid EDTA and remove all the dentinal debris so that you can see the dentinal map very clearly, or a developmental groove. Then you can use your DG16 probe or a canal detector dye, or search for some bleeding spots if they are present under the magnification. If you are unable to get any orifices in this way, you can start troughing. Either you can use a Startex 1, which is a narrow tip, or you can use an EndoGuide SS white burr. And this troughing should be done at least 1 to 1.5 millimeter deeper, connecting these two orifices, as you can see into this lower picture. So most of the time, you will get the canal in this case. And these canals are confluent. That means they have a separate opening, but they'll merge with the main canal. In around 20% of the cases, you will have a fin type of extension. That means you will feel that my mesiobuccal is slightly oval. It's not round. It's because of this fin extension of your middle mesial or MB2 canal. In very rare cases, you will find a separate orifice from the tip to the exit. You will have a separate cases. And if you are lucky, you get middle mesial 2 or a MB3 canal. But if you are unable to find out any additional canal, you should spend extra time on irrigation, activating the irrigant more into the mesial canal systems, because there is a possibility that the fin or anastomosis is present in the deeper part of the root canal, because it's a mesial root canal system. So remember, friends, we are not treating the root canal, we are treating the root canal systems. So please spend sufficient time and teach your students also to do so in a day-to-day practice. So the next part for me is the obturation. And nowadays, we all are shifting ourselves towards a bioceramic sealer. Now, why this shifting is done, and what are the advantages of shifting towards a bioceramic sealer based obturation? So we'll discuss this part. the main purpose of a sealer is to overcome the limitation of the gutta percha, because gutta percha is a material which doesn't bond to the dentine, as well as it also undergo a shrinkage. So the sealer will take up this space. Now, evolution of sealers has happened from the zinc oxide eugenol based sealer to epoxy basin rest sealer, and now to a bioceramic based. So for the zinc oxide eugenol based sealer and epoxy basin based sealer, the concept which is used is known as a minimal sealer interface. Because at that time, they were considering that the sealer is a weak link in the obturation. Its role is only to, to fill the space between the gutta percha and the tooth. There is no other role of sealer. So what concept was given is we have to go for lateral condensation technique, vertical condensation technique, so that the maximum amount of the gutta percha will take up the space and the sealer should be minimum. So in effort to do this, we used to use sometimes some heavy condensation forces. Now, if you have done some overzealous preparation where the remaining dentine thickness is less, along with this active condensation, you will ultimately result in a cracking of the tooth or a crack development on the root. And zinc oxide eugenol based sealer was cytotoxic also. So if it extrudes in the perioapical region, patient will have a pain. And I remember this very easily because our time, PG time, was a time where we were using the zinc oxide eugenol based sealer only. So it was very routine that we normally tell the patient, you will have pain for 3 to 4 days. Gradually, it will reduce. So normally we used to give them the anti-inflammatory, and it is normal. It was considered normal. Whereas when we have changed to resin-based sealer, they were superior in physical properties than zinc oxide-based sealer and more dimensionally stable. But it doesn't bond with the tooth, most of them, and they do not wash with the time. But again, the concept was same, that is a minimal sealer interface. But when we have shifted ourselves to bioceramic sealer, which is also known as a sealer-based obturation or a passive obturation or a hydraulic condensation obturation or a bonded obturation, all 4 names are used for this. The reason for having a better outcome with the bioceramic sealer is it is a nanoparticle containing sealer. It is biocompatible, rather bioactive. It chemically bonds with the dentine. It's antimicrobial because of its high pH. It is hydrophilic in contrast to previous, which were hydrophobic. It's a dimensionally stable, non-absorbable, osteogenic. Many of them who are using are telling that perioapical lesion heals on its own. So it's an osteogenic. And if your gutta percha are silinated with this bioceramic nanoparticles, then it will actually create a monoblock. So the bioceramic condensation technique is known as a no condensation technique. You do not have to do condensation. GP acts as a condenser. It is less technique sensitive and less time consuming. So let us understand what this hydraulic condensation technique is. So here you have to take up, once your canal is ready for obturation, you take this sealer in the cervical or till middle 1/3 part. And then either you can use your Lancero spiral or you can use your master cone and take this sealer up to the apex. Now make sure this transition should be done slowly. It should not be done rapidly. And there has to be sufficient space between the gutta percha and the canal wall. So your size of the gutta percha should be such that there is a sufficient space for the sealer. That doesn't mean you have to keep a thin cone and a lot of sealer, but yes, there has to be a sufficient space. Once you have inserted it up to the working length, then wait for a few seconds so that the remaining sealer will come on the top. They will flow and ooze out from the coronal surface. And then the most importantly, whatever you are using, touch and heat or a hot burnisher, should be taken 2 to 3 mm away from the canal orifice. Normally, what do? The heated instrument, we apply it on the canal orifice and we sear the gutta percha at that time. This should not be done. The simple reason is these these heater or carriers are heat carriers are having a very high heat. So they lead to the evaporation of water. And the water is very important for the setting mechanism of this bioceramic sealer. So in the absence of water, the setting mechanism may not be complete. And so you will not get the full benefit of this sealer. So this is how your obturation is to be done. So now the question is, even that was to me also, that this bioceramic sealer should not be used because retrievability is difficult. So there are two myths which are existing about the bioceramic sealer is, number one is you can fill entire canal with the bioceramic sealer. So this you cannot do. Neither the hydraulic condensation technique recommends that you should fill the canal with the bioceramic sealer. Always they say that the gutta percha is act as a condenser. So gutta percha should be used. Now, suppose you have an oval canal, like a distal canal or a palatal canal. Instead of one, you can also insert 2 or 3 gutta percha cone. What they are telling you not to condense. You don't do active condensation, lateral condensation, and vertical condensation. So gutta percha should be used for the obturation. So anybody who is obturating the canal with the bioceramic sealer, totally with the bioceramic sealer, it's a fault from the operator. It is not the fault of a sealer, number one. And second is, bit about bioceramic sealer is it is very hard as a your glass ionomer or composite, and it's difficult to retrieve. It is not as hard as you think. The consistency of the sealer is also such that it can be easily retrievable. So what I would recommend is you follow the technique properly. It is possible that in cases where you have acute curvatures, where gutta percha is literally not it is not possible for gutta percha to go. At that time, if a part of a apical 2 or 3 millimeter, if they are filled with a bioceramic sealer, it's still okay. But technique recommends that you should use it along with the gutta percha as a condenser. Right now, the question is if you have to remove this bioceramic sealer. So now, if you have followed the technique properly, and if the gutta percha is there as a core, your technique will be the same. You remove the gutta percha as per your normal retreatment protocol, and you will be able to remove the gutta percha. The remaining part of the sealer, which is in contact with the canal, can be removed with the like the nitide flexible files, like your endosequence files or a BioRace files. These are also from Bressler company. If it is in the coronal part, if it is filled with the bioceramic sealer, you can always use your ultrasonic tips to remove the sealer from the canal under the magnification. And the challenges are only there if it is in the apical 1/3 and you need to go for the retreatment. So remove the gutta percha from the coronal region using a normal protocol, and then you can use this BioRace or endosequence files. Unfortunately, I do not know any file compatible to this are available in India or not. But most of the time, if you follow the technique properly, there are less chances that you will end up having a complication. The last part of my presentation is the sealer puff, whether it should be present or it should not be present. Because all our students will come to us very proudly and show us this puff. And we feel that, oh, nice, great, you created a puff. But these puffs are not required. It's rather a show off. The reason for that is when we do the chemomechanical preparation, we use various irrigation. So from this lateral and accessory canal, a part of the necrotic tissue will be removed from the entrance, whereas they are still present inside. So when and these inside tissue could be inflamed, infected, or they are associated with the periradicular tissue. So in cases where this area are filled, they are actually not obturated. Still, there are some tissues which are enmeshed with this filling material who are in an inflamed or a necrosis condition. So the clinician's skill or ability to produce a sealer puff will not necessarily result in a successful endodontic therapy. Whereas Dr. Ruddle says that we never want any surplus material in the endodontic therapy. So purpose of endodontic therapy is never to create this surplus, any puff or so. But it's a result of hydraulic safely generated to active a 3-dimensionally packed root canal system. So when we pack it, these puffs will create. There are countless cases which have shown that the healing happens over that, but that does not mean that we want this surplus material. So if you have not created a puff, or don't pressurize the student for creating this puff, or give them an credit that, oh, now nice, the puff is present. So it's a debatable. They are good or they are not good, but they will not guarantee the success of your final treatment. So with this, I would like to end my presentation. So on a last note, I'm a hardcore fan of Dr. APJ Abdul Kalam. So he said that teaching is very noble profession that shapes the character, caliber, and a future of an individual. If people remembers me as a good teacher, that will be the biggest honor to me. And same applies to me also. Thank you so much once again for your patient hearing.
Thank you, Dr. Nimisha. It was a brilliant presentation with a lot of clinical inputs which you have shared, and which I think over years for us also it is needed to assimilate all the small details, small facts which you have put. And I hope that we will also deliver it to our students through you. And the expertise that you have presented this with, it definitely was a lovely presentation, and I am truly enlightened to be a part of this session. And I wish I could spend some more time learning more things with you. But the time constraints, there are some questions which the people would like to take. And we have some questions which have come up. And this question is from Dr. Paromita Mujumdar. She wants to know the bioceramic sealer can be ejected using tips available with the pack. So do you advocate this instead of lentulospiral?
Madam, what I have gone through is the original hydraulic condensation technique. So those who have invented, the Bresler company has posted its protocol and the video. So they say that you can use even a master cone gataparcha. Your this lentulospiral is a figure which they have shown, but you can use it with the tip, you insert it and then take it with the master cone gataparcha. That's an easiest way and the safe way, even I feel.
That's right. When you speak of hydraulic pumping of the sealers, I would agree with you, rather than using a lentulospiral. So that would be a good way to use it. So we have another question that this question is they want to know some companies, to name some companies of electric handpieces.
Yes, the electric handpieces as of now available for Unicorn. We have an NSK handpieces also, as well as now the economical version. Nearly, I just inquired, it's around 77,000. The motor plus handpiece is from Neo Endo, 18th company. The other two are reasonably expensive. The NSK is nearly 1.7 lakhs and Unicorn, I do not know the cost. But all the companies are now coming up with the electronic handpieces, and we have to shift gradually towards this. There is no option, because it will serve the purpose of slow speed as well as high speed. And we get a very consistent cutting with this. So I think in a newer future, it all will shift, and the prices will also fall down.
Yes, especially yes. In the pandemic, also there was a lot of attention that came with the use of electric handpieces, and that time also, as you said, the cost factor was a major limiting thing when it came to purchase of these handpieces. So we have one more question, that is, from where do we buy the DuraCut burrs? And this is from Rakesh Singla. He has asked you this question.
DuraCut burrs are as of now marketed by the Bresler company. As I said, one who manufactures the endosequence sealer. So it's a Bresler DuraCut burrs. There are many DuraCut burrs are available, but I have gone through their content and the literature. But I recommend only one as of now, which are actual DuraCut, which the company recommends. Because on the name of DuraCut, there are many burrs are available, but they are actually not used for the ceramic crown removal. So as of now, one. Yes.
So we have one more question which they want to know is the electric handpiece management of heat production with the electric handpiece.
No. You have it's like an aerator. You have ample of copious water along with this. The only advantage is, like, suppose now when I have done this MFMA, like I realized that I have to create only 0.5 mm of margin. And with my aerator, I was literally shivering because it is difficult to cut less, it's easy to cut more. So I have to be very careful about the vibration. So those all I can control. So it is having a reduction gear that is altogether a different science. 1:5. So it can work at 80,000 RPM as well. It can work at 4,000 RPM as well. So all this adjustable speed along with the water, we can use it. The only advantage is it's a very precise cutting, noiseless cutting, and we do not have vibration. Like in aerota, we have a vibration. Those vibrations are not there.
Yes. So there is another question which we have, which asks, can you explain the availability of various endodontic ultrasonic tips?
Ultrasonic tips are available depending upon the use you want to, for simplest, most commonly is the statics, which are the most studiest tips we use normally for even calcific removal, for canal refinement, and for the troughing of this pulp stone and all that. Even we have a retro tips are available from the satellite endo success kits. So those tips are for the surgeries. And this all are the specialized tips which may have to, I have a brochure. Anybody can contact me and I will be happy to share all this information from the company brochure itself.
Okay. So we have last question.
Madam, can you please?
Eva, can you repeat it? Your connection is lost a bit.
Sorry, yeah, I shall repeat it.
Yeah.
Dr. Saloni wants to know if bioceramic sealer can be used with single cone obturation. If bioceramic sealer can be used with single cone obturation.
See, it is a recommended
am I
technique.
audible?
Yeah, ma'am. It is known as a single cone obturation technique, but that does not mean, like, as I said, your cone selection should be such that it will occupy a major space of the root canal and the remaining space can be filled with the sealer. So normally what we used to do, I used to use my spreader and add a cone as tightly as possible till it will not go beyond the cervical 1/3, right? That active condensation should not be done. If the sealer will take care of the surrounding part, it is okay. But at the same time, if I have a large canal, like an oval shaped canal, like in a distal or a palatal or a premolar, instead of one, I can also insert 2-3 cones. The purpose is active condensation should not be done when you are using bioceramic. And if the sealer is present, and that will seal off along with the gutta percha.
So, thank you, Dr. Nimisha. It was very a session of full packed of a lot of attention to your entire presentation. Wonderfully presented cases, and I would like to acknowledge the presence of Dr. Meena ma'am, Dr. Sarjeev sir, Dr. Kavalpreet, Girija ma'am, Prem, Dr. Rajkumar, Sujata, Kavita, and Dr. Mandana. Dr. Shalini, who are all present in this session. And I want to thank Dr. Mahalakshmi ma'am for always giving me this opportunity and always making me feel special to be a part of all the academic events, which is always on the forefront at SRM Dental College Hospital. I think she is really leads the torch when it comes to organizing these type of activities and execution. And not only that, it doesn't limit there. It is about involvement of everybody who equally participate with the same energy and motivation. And she is truly a motivation to all of us. And I hope she continues to be doing this. I thank her again for all this opportunity that I am present here to be a part of this session. Thank you.
Thank you, Vibha. As you said, the second last part where you said that equal energy and enthusiasm by our others as well. So that is what keeps this and me and the programs that come up. That extra flavor comes mainly because of them. Mine is just the idea. So execution, everything is by them. So that's why. Thank you so much, Nimisha, once again for wonderful presentation. Just apt and just what we wanted. I wanted actually for you to deliver, and you have done it superbly, I would say.
Thank you,
again, Dr. Vibha Hegde, for your wonderful moderation and being there all the time. And it's It's an honor and a privilege to have you as our friend and this for all the programs. You never say no for anything, I know, so that I can always fall back on you.
I can't say that. I can't say no.
Both beautiful ladies for gracing this occasion today. Thank you. And over to you, Srijana.
Thank you, ma'am. So today's session ends here. We had only one lecture lined up for today. Let us all meet tomorrow again for a wonderful day of learning.
Thank you.
Thank you. Thank
Bye-bye.
you.
Much.
Bye.
Bye-bye.
Thank you.
Bye.